Hello, my dear students. I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. Today, I have come with the second part of the mammary gland series, which means that I've already covered one lecture on mammary gland, which is development and histology of mammary gland. Today, I'm taking the second lecture, which is gross anatomy of mammary gland, lymphatic drainage, and applied anatomy. Lecture 1, I have covered a lot of the basics of mammary gland. I want you to look at that as well. Please don't miss lecture 1. That is as important as lecture 2. Before we begin, a question for all of you. Following structure contributes to the formation of mammary bed. Is it pectoralis major, serratus anterior, external oblique, transverse sectoris? Or maybe write a note on lymphatic drainage of mammary gland. Draw a label the mammary bed and so on. So if you want to be able to answer these questions comfortably, you need to have knowledge of mammary gland. Let's get that knowledge. Okay, so elephant on the screen, what fun? No, this elephant has come with a note for all of you that the topic we are discussing, the mammary gland, is something that is uniform to all mammals. All mammals have an ability to nourish their offspring through milk produced by specialized glands, which we call as mammary glands. So like they have breasts, we have breasts. Okay, fine. So what is this breast made up of? It's made up of breast tissue and areola and the nipple. In the males and in immature females, the breast tissue is negligible, the areola is fully developed, and the nipple is small. In a mature female, with time, puberty, the breasts will develop under the effect of ovarian hormones. Soon the breasts are well developed. In pregnancy and lactation, the breast development gets completed. Okay, so this is in short. I didn't give you anything that you didn't already know. But, okay, so what is the shape of mammary gland? It could be conical, hemispherical, it can be pendulous. Now we come to the gross anatomy of it. What is the extent of mammary gland? What we see, the mammary gland doesn't really give you the anatomy of it. It extends from second rib to sixth rib, horizontally extending medially till the sternum and laterally till the mid-axillary line. This mammary gland is related to superficially to the skin, superficial fascia, and on the deeper side, it is related to the following. Now, this is important. On the deeper side, it is separated by a space from the underlying structures. The mammary gland has an apex and a base. Now, this is the base of mammary gland, okay? This is separated by a retromammary space from the rest of the pectoral muscles. So, this is the pectoral fascia and this is the pectoral muscle beneath it. So, a clear space separates the mammary gland from the pectoral muscle, beneath which obviously there is the chest wall. So, what is mammary gland related to? Superficially to skin, superficial fascia. On the deeper side, the mammary base is related to retromammary space, fascia covering pectoralis major muscle, and the chest wall. These are the relations of mammary gland. We'll be discussing each of these some more. First, let's talk about what is called as the mammary bed. Okay, what is the meaning of mammary bed? It's the base, it's the area or structures on which the base of mammary gland rests. So here you are seeing the mammary gland. You can clearly see that it is resting on pectoralis major. Medial 2/3 of this bed is made by pectoralis major, and digitations of serratus anterior. Lateral 1/3 is made up of serratus anterior and lower part is made up of external oblique aponeurosis. So these are the structures that are forming the mammary bed. Structures deep to this are subclavius, pectoralis minor, clavipectoral fascia. All that will be lying deep to the immediate mammary bed. Now I talked about something called as a retromammary space. Remember 2 minutes back? What is this? So understand that this is the pectoralis major. This is the deep fascia covering the pectoralis major. This is the base of mammary gland, and in between them there is a space which is loose areolar tissue, which is called as the retromammary space. Question is, how is it relevant? Why should I know it, ma'am? You should know it because if the mammary gland is clearly movable on the underlying muscles normally. Okay? But sometimes when there is cancer of the breast, the cells begin to grow inwards. Please look at the diagram. And they anchor themselves to the pectoralis major muscle. Okay? Now if you try to move the mammary gland on the underlying muscles, it's difficult. Because now the cancer cells have anchored it to the pectoralis major, breaching which space? Breaching the retromammary space. So that is the relevance. Right. This space is also called as the Chasinax bursa. Okay, one more interesting for many of you. This is the space in which a silicone implant is put for breast enhancement surgeries. So you can see that sometimes a person has a small breast and then they put in this silicone implant. Where is it put in? It's not put inside the breast. It's put behind the breast tissue in the retromammary space. I've shown it to you, see. Correct. So there's another term you should know called axillary tail of Spence. Axillary tail of Spence is, what is the meaning? That's a little bit of the mammary tissue that is extending inside the patient's axilla by passing through a hole in the axillary fascia. The hole in axillary fascia is called foramen of Langer, and the tissue that goes inside the axilla is called axillary tail of Spence. Students, if you're enjoying this lecture, please like and subscribe to my channel and do share your thoughts in the comment section. Right. So, description of the breast, let's continue. We know it's made up of breast tissue, areola and the nipple. Not every time the breasts are symmetrical. Sometimes the right may be larger than left. Let's first talk about the nipple and the areola. Why are they darker? Because the epidermis here shows a lot of dermal papillae coming inside to the surface. Each dermal papilla is carrying blood vessels with it. So what happens? So much of blood is coming quite close to the surface, giving a darker appearance. This is the same that happens with your lips also. Right. So what is this area which we refer to as the nipple and where is it present? It's present on the fourth intercostal space. It's almost conical to cylindrical. It is pierced by 15 to 25 lactiferous ducts individually opening on the surface. It's not one gland. Mammary gland is a number of glands put together. The nipple is having a smooth muscle in it. Smooth muscle that is circular, which when it contracts, it causes the nipple to protrude outwards, which is easy for suckling. It also has a longitudinal muscle, which when it contracts, causes the nipple to come back to its normal position. It has a strong nerve supply because it has to set off the reflex which goes to the brain. So a lot of sensory nerve endings here. And however, note that if the nipple is retracted, it could be indicative of underlying cancer. A bloody discharge from the nipple can indicate cancer, but may also indicate an intraductal papilloma. What about the surrounding area called as the areola? The areola is darkly pigmented and it becomes further dark after the first pregnancy, and this is irreversible change. The outer margin of the areola may show you some tiny tubercle-like structures which are called as tubercles of Montgomery. These are modified sebaceous glands and they secrete an oily substance which helps to moisturize both the areola and the nipple. It also has a different pH, preventing bacterial infection. This matters during the process of lactation. The area also contains sweat glands and accessory mammary glands. Areola has no hair. The subcutaneous tissue has no fat in it, and underneath it there is a sinus called lactiferous sinus. I'll talk about it subsequently. Beneath it there is an important plexus called lymphatic plexus of Sappi. Please note this. We'll come back to it later. Right. So, description of the breast itself. Remember that now this is the schematic representation of the breast. You can see how it's covered by skin, superficial fascia containing subcutaneous fat, and then a lot of lobes that are radially arranged. Okay, all of them are radially arranged like the spokes of a wheel. All these are separated from each other by connective tissue septa. Each lobe is made up of a number of lobules. This is the basic. That's the lactiferous duct through which it finally opens on the surface of the nipple. Question: why is the surgical incision on skin taken radially? If you're trying to enter into the breast tissue, why do you want to take a radial incision? Why don't you take a circular incision? You have to take it radially because that's the direction of the ducts. You have to save the ducts. If you go perpendicular to the duct, you're going to actually destroy the duct. So this radial incision is to take care of the underlying glandular tissue. As you can see, this is another schematic diagram. This is one lobe. Each lobe is made up of several lobules. Each lobule is made up of alveoli, which drain into ductules, which drain into intralobular ducts, interlobular ducts, finally drain into its own lactiferous duct, which dilates to form lactiferous sinus just beneath the areola and finally opens on the surface of the nipple. So the milk flows in this direction. This is the basic structure of a mammary gland. The mammary gland, for purpose of description, has been divided into several quadrants, such as upper outer, upper inner, lower outer. What about this little thing that has gone into the axilla? The axillary tail of Spence. This is quadrant distribution of mammary gland. Right. So this mammary gland receives blood supply from a number of branches. What are these branches? This is the aorta, which is giving out brachiocephalic trunk, which is dividing into common carotid artery and subclavian artery. I'm sure you know that. The subclavian continue into the upper limb as axillary artery. First branch of subclavian, the internal thoracic artery, gives rise to perforating branches in the second, third and fourth intercostal space, which give rise to medial mammary branches. So this internal thoracic gave rise to branches in second, third, fourth space which supply medial side of the mammary gland. Similarly, lateral thoracic artery, branch of second part of axillary, gives rise to lateral mammary branches. So also some thoracoacromial also helps in this supply. Upper part of mammary gland is supplied blood by superior thoracic artery, part of first part of axillary artery. And posterior intercostal arteries, their lateral branches, supply the mammary gland from the side. So the four set of branches supplying the mammary gland are internal thoracic, superior thoracic, lateral thoracic, and lateral branches of posterior intercostal arteries. The venous drainage is a little peculiar. This is the mammary gland. Just beneath the areola, a circle of venous drainage is formed, which is called circulus venosus. From the mammary gland, blood is drained laterally into axillary vein, medially into internal thoracic vein, posteriorly into the posterior intercostal vein. Now you have started to wonder, ma'am, why are you giving me so much information? Students, this is interesting. See how blood goes from mammary gland into posterior intercostal vein. Along the posterior intercostal, it goes to azygous vein. The azygous vein is communicating with internal vertebral venous plexus in your vertebra, from where it is in communication with bones like cervical vertebrae, humerus, clavicle, and so on. Sadly, cancer of breast spreads via this method to the bones, and this is called retrograde metastatic spread of cancer to the bones. And that's why you have to know the venous drainage. I don't have any particular pleasure in giving you such information. This is the route of spread of cancer. That's why you should know it. Right. A lot of nerve endings from 4th, 5th, 6th intercostal nerves carrying sympathetic supply as well come to the breast tissue. We now come to a very important part of today's discussion, lymphatic drainage of mammary gland. Students, lymphatic drainage is to be studied under lymph nodes and drainage. Because many of you don't know lymph nodes of the chest region and axillary region at all. So come, let's understand the lymph nodes first. Here you're seeing the axillary group of lymph nodes which you will find in the axilla. It consists of anterior group, lateral group, posterior group. All three will drain into the central group, which drains into the apical group of axillary lymph nodes. Also present are infraclavicular and supraclavicular lymph nodes and medially parasternal internal mammary lymph nodes. Now this is the basic pattern on which lymphatic drainage will take place. If you don't know this, you're not going to understand anything. Okay, so learn this first. Right. There is also posterior intercostal group of lymph nodes which also play an important role. So now let's divide our lymphatic drainage into lymphatic drainage of mammary gland tissue along with that of nipple and areola. Then you will say what is left? Lymphatic drainage of overlying skin minus the nipple and areola. These are the two groups in which we have divided the lymphatic drainage. Let's talk about one, that is gland and nipple and areola. So understand that the lymph forms plexuses within the gland. Lymph forms a plexus beneath the areola called lymphatic subareolar plexus of Sappi. Remember, I asked you to remember it? Subareolar plexus of Sappi. Subareolar plexus of Sappi, and within the gland, some lymph plexuses. All this is the lymph you want to drain. How does it drain? And I've given you all this, 75% here, 20% there. You're going to wonder, ma'am, how to remember all this. Let's take a look at the image now. Okay. So, the parenchyma lymph plexuses and the lymphatics from subareolar plexus of Sappi. 75% of this lymph goes to anterior group, posterior group, central group of axillary lymph nodes, and finally to the apical group of lymph nodes. 20% of it comes medially to the internal mammary lymph nodes, and 5% of it goes to the posterior intercostal lymph nodes. Now understand 75, 25. Okay, so that's the lymphatic drainage. Now I think you shouldn't find it difficult. Lymphatic drainage of the skin except the nipple and areola. How does that go? Let's take a look. The outer part goes to axillary node. The upper part goes to supraclavicular nodes. Inner part has its own distribution. Again, you will feel, ma'am, too much of words. How to remember? As usual, images will help you. This is an image, orient yourself. That's the clavicle, sternum, mammary gland, diaphragm and liver. Okay? Now, the outer part goes to axillary lymph nodes. The upper part goes to infraclavicular and supraclavicular lymph nodes. The inner part is divided into upper and lower. It goes to internal mammary lymph nodes. Some of it crosses the midline and goes to the opposite side. What happened just now? What happened just now was a cancer of one side has crossed the midline and gone to the opposite side, because now lymphatic drainage is not unilateral, it has gone to the opposite side lymph nodes. Similarly, lymph from other side also is coming across midline. Okay, the lower medial quadrant also travels below the diaphragm to go to hepatic lymph nodes. This is subdiaphragmatic spread. And also some of the cancer cells are dropping into the peritoneal cavity, sometimes anchoring on the surface of the ovary, causing formation of what is called Krukenberg's tumor. What is it called? Krukenberg's tumor. Okay, this is indicative of a worse prognosis for the patient. Right. So this is how the skin of the mammary gland, over the mammary gland, except the nipple and areola, is being drained. Finally, students, there is a lecture 3. I want you to see lecture 3 where I'll tell you how to remember all this with the help of diagrams. I have taught you once. I will tell you how to draw and learn it again. Please don't miss lecture 3. Right, we now come to the last part of the class, applied anatomy. I want to present it in the form of questions. Bilateral nodes are to be examined when there is unilateral carcinoma of breast. Why? If one breast is showing cancer, why are you examining the other breast? You are doing this because there is always a chance of crossing midline and spreading of cancer to the opposite breast. You may treat one side and leave the other side untreated for the problem to come back in the patient. What is Peau d'Orange? What is Peau d'Orange? This is the skin of the mammary gland, looks like an orange peel because there is edema in the skin. The lymph nodes are blocked, maybe with cancer, so the lymph is not getting drained. This results in edema of the skin, and the points where hair follicles are there, they look like the hair follicles are retracted, and it has a peculiar orange peel-like appearance that is called Peau d'Orange. What is mammography? Mammography is a pre-cancerous, it's a screening tool for cancer where the breast is held between two metal plates and examined radiologically for early changes of breast cancer. Is it possible to inherit breast cancer? What do you think? It is not? It is. There is a peculiar mutation in the BRCA1 and BRCA2 genes which is associated with breast cancer, which is what happened with Angelina Jolie, isn't it? That's why she underwent a bilateral mastectomy, because she saw these mutations and therefore decided to take a decision of mastectomy. Now think that you have a patient who's come with a lump in the breast, okay? What are the questions you will ask yourself? Is the lump mobile or fixed? Is the lump hard or soft? If it is fixed and hard, it's likely to be malignant. If it is soft and mobile, it's likely to be something called fibroadenoma. What is fibroadenoma? Fibroadenoma is a little growth in the mammary gland which is non-cancerous and it tends to move. It's also called as a mouse in the breast. What a horrible analogy, but it has been used for years together. So because it moves around, okay, so it's removable and it's a condition seen, but how will you know what to do? You will do an FNAC, fine needle aspiration cytology. You will take a needle and remove the tissue and examine it, or you can do an ultrasonography, but you will take that decision and decide whether it's a cancer or it's a fibroadenoma or any other pathology. So how will you treat such a condition? If it's a small size cancer, then you can remove the mammary gland, the tumor and the axillary lymph nodes. You remove the tumor and the axillary lymph nodes, you expose the patient to radiotherapy. But if it's a large tumor, what will you do? You will remove radical mastectomy, entire mammary gland, all axillary lymph nodes, chest wall muscles beneath the breast, everything is removed. This is called a radical mastectomy. Then you take the patient up for radiotherapy and chemotherapy. And then let's hope the patient makes it through. So this ends my lecture 2 on mammary gland gross anatomy, lymphatic drainage and applied anatomy. Lecture 3 will be made up of a series of diagrams which will help you to recall lymphatic drainage better. Lecture 1 is extremely important. I advise all of you to go and see lecture 1 to be really able to confidently say, yes, I know the anatomy of mammary gland. It's important clinically too, students. These are lectures. This is a lecture series which I consider as of grave importance. If you enjoyed and you learned from this lecture, please like and subscribe to the channel. It will encourage me to make more of such relevant lectures for you. Yes, I enjoyed taking this class, but again I will say I took this class with complete responsibility. Thank you so much, students.